Welcome to WTVI's HealthWise. I'm your host, Joey Pop. We're about to address common spine conditions that could benefit from surgery. Back issues are among the highest reasons why many of us go to the doctor. Now, if this rings a bell with you, stay tuned the next hour with medical experts from Ortho Carolina. We welcome Dr. Bradley Segebarth and Dr. Stefan Renaud. We also welcome your questions by calling us or sending an email to jpop@wtvi.org. Once again, I got the mobile device out here so I can take your emails directly on set, make sure I'm on silence here. And call us with the number on the screen, and we'll just have a good hour education of what's going on with common spine conditions. Welcome, gentlemen. First appearance on HealthWise.
It is. Thanks for having us.
Dr. Bradley Segebarth, where are you from?
I actually grew up in Kentucky. I did both my undergrad and medical school there. And then,
at UK?
Yep, UK. Then did residency training, orthopedic training at Vanderbilt before doing a year here in Charlotte. So,
well, welcome.
Thanks.
And you've been here just under the year, you say?
Yeah, actually spent a year here doing a fellowship and then went into practice for a couple years back in Tennessee and then moved back just last fall.
Well, great. Welcome. Dr. Stefan Renaud, welcome to Charlotte. You're new as well.
Yes, I am. Thank you.
Where are you from?
I grew up mostly in the Northeast.
Now, when you say the Northeast, what's that? Boston?
Mostly Connecticut, but a little bit all over.
Yes.
We moved around quite a bit.
Mm-hmm. And then from there?
Then I did my residency training in the Detroit area, and then finally did my spine fellowship in Seattle, and then I came here this past fall in October.
It's been a U.S. tour for you then.
That's right.
And who knows, it could end up being a worldly tour. You hope to stay in Charlotte for a while, though?
I do. So far, so good. Everyone's been very accommodating, and I like it.
Well, great. Now, where do both of you practice? Dr. Segebarth?
Most of my clinics are at the university area. And most of the operations I can perform out there, but some actually operate in town. Some of the bigger cases.
You're a medical doctor?
Yes, sir.
And you're a surgeon.
That's right.
And we're going to be talking about surgical procedures. Dr. Renaud, you're a DO, a doctor of osteopath, right?
Correct.
And my first question to you is going to be, are you also a surgeon?
I am.
Now, tell me what a DO does in addition, as opposed to an MD.
Well, really, DO was actually founded by an MD around the time of the Civil War, and it was just kind of a philosophical difference where that particular practitioner who founded it felt that the body had an inherent ability to heal itself. So kind of a holistic approach. And over the last 200 years, that different philosophy has really become back into the mainstream. And essentially today, there's really nothing different that we do than MDs do.
All right. So as a DO, do you also seek alternative medical practices?
Sure. I think that those things are fine, particularly in the spine world, you know. I mean, things like physical therapy, chiropractic, acupuncture, all those things certainly help people control their back pain and become more functional. But some of those we'll call alternative medicines, we just don't have great scientific evidence behind them.
But as a DO, you have the understanding.
You know, my training in musculoskeletal care is somewhat more focused than MD. But as far as do I have any particular knowledge as to how to do acupuncture or chiropractic care, not really. Those are separate fields of their own.
All right. Now, where do you practice?
I practice particularly in the western corridor of Ortho Carolina. So I cover.
What does that mean?
I cover the Gastonia area as well as Shelby, and I practice mostly out of the Caramount Health System.
Oh, great, great. And Caramount has been a part of our mission here on HealthWise, and that's super. So do you guys ever see each other? Here you working for the same company, but just at social gatherings, or do you actually see each other in the OR?
Well, we actually have a lot of interaction. Our group, as you know, is a very big group, but within the spine section of our group, we have a lot of kind of common conferences and things where we can all interact and bounce cases off of each other, and really kind of helps everyone's experience by sharing cases and getting extra input. So we do come together on a weekly basis.
That's great. And you're both young, new to Charlotte, so you have a lot in common.
I'd say so.
Yeah, and happy to be here. And we're happy you're here, too, because the next hour really should be quite interesting. It seems like every time we do back issues, the phone lights up. So we look forward to talking with you, but we first have some slides to go through, so let's go right to it. Dr. Renaud, I'm going to start with you with this first slide, talking about acute problems here. So go to that first slide, and what is your message?
Sure. So this first slide really is just some demographics and some statistics about back pain. It's the #2 most presenting complaint to primary care physicians. That's behind upper respiratory infections or the common cold. So very, very common that people have back pain. And the next point is 75 to 80% of sudden onset or acute low back pain improves in 2 to 3 weeks basically on its own, maybe with some minor anti-inflammatories or regular kind of over-the-counter stuff. And 80 to 90% of people improve within 2 to 3 months. So really the vast majority of people that have sudden onset back pain get better on their own without any sort of intervention.
But then after that 3-month period, it's time to call a specialist?
Probably. We'll get into some details as to symptoms that are related to certain conditions and things like that. But I think that that's pretty reasonable if you've tried some activity modifications, over-the-counter medication, etc., and you feel like your back pain's not getting any better or certainly getting worse, and if you start developing pain in your arms and legs, those are all kind of signs that you should probably be evaluated by someone.
And almost 5.5 million Americans impaired by low back pain every year. That has to be a phenomenal number. Where does that rank as in terms of other reasons why people go to the doctor?
I think very common, and honestly, I don't know a specific number, but I think probably the healthcare dollars that are attributed to dealing with back pain are probably astronomical.
Yeah. All right, so it really eats into the system, too, for that care. Yes. All right, let's go to the next one. What causes back pain? And that's what this slide addresses. Dr. Stefan Renaud is going to continue talking about this.
Sure. So we just talked about how common back pain is. And the one other bullet that we didn't touch on was that 60 to 80% of people will have an episode of sudden low back pain at some point in their life. So that's pretty much everybody. So now what's causing this back pain? And I want you to really pay attention to the top 2 bullets in this slide.
Okay.
The first one, lumbar strain or sprain. 70% of people who have low back pain, this is the cause. What does that mean? Well, this is what I always tell my patients is, somebody has either had or knows someone who has had tennis elbow or golfer's elbow or rotator cuff tendonitis. Well, sprain or strain of the back is basically the same thing in your back. So it's the muscles and tendons that are around the spine that become inflamed, irritated, and can go into spasm. So, and just like people who have had those problems, like a tennis elbow, it can be very painful. Well, the muscles in your back are much larger and stronger, and they can really become debilitating.
And longer to recover?
About the same amount of time.
Okay.
Like we said, typically 2 to 3 months.
Okay.
And people will get better. The other bullet I just pay attention to here is degenerative changes. So that's just kind of a term meaning arthritis in the spine.
Is there anything we can do to stop that or to reverse it?
There's not a lot. I mean, just like in other forms of arthritis, there's probably some genetic factors. Weight reduction is probably something we can do. Tobacco cessation. Tobacco has been shown to cause some drying out of the disc, some aging of the spine. But really just trying to stay as healthy as you can be, just like for your heart and lungs that you should exercise, stay active, etc.
Good diet.
Exactly.
Okay. All right, and then the others there, you saw the percentages, and they were even lower. So, Dr. Segebarth, let's get you back into this conversation. You're going to show us this slide on just how the spine's made up. And just to break this down, Dr. Segebarth is going to be speaking mostly of upper back pain around the neck, and Dr. Renaud will be addressing the lower back during this hour. So you're up.
Okay, thanks. This slide actually is a lumbar vertebrae, so this is lower back, but it demonstrates a motion segment of the spine. So this is kind of how the spine is built, and you can see the red circle there that outlines the nerve root. What's important about that is in front of the nerve root is the disc, which people hear a lot about, and behind the nerve root is the facet joint. So the nerve root is kind of sandwiched between those two structures, and that becomes important on the next slide as you can see what happens over time.
With what we were talking about, degenerative change.
That's right. With age, like anything, the body changes over time, and the discs lose water, and they lose that kind of shock absorber cushion. And so you can begin to form bone spurs around it. The bone spurs can form around the end plates there on the upper and lower end of that disc. But also, the picture on the right demonstrates the facet joints. You can form some bone spurs and arthritis there.
When you say spurs, what does that mean?
We're talking about arthritis and osteophytes. There are lots of different names for it. But the bottom line is all these structures can crowd the space available for that nerve root. And so the hole that is depicted white there on the left, that's where the nerve root was coming out. And so if too much is crowding that hole, then you can have some impingement or some pinching on the nerve root that can cause some symptoms into the legs if it's the lumbar spine, or into the arms if it's the neck.
And when you say symptoms, what are we talking about? Is it sharp pain? Is it a numbness? What?
Yeah, it can be variable symptoms, but mainly what we're talking about when we describe nerve pain is our pain that radiates into the arms or legs. And so it can be pain, it can be numbness and tingling, or funny feeling, sandpaper type feeling. But pain that goes into the arms or legs in a nerve root distribution, that's common language that we use, but really it's it's something that not everybody associates with being a problem in the neck or a problem in the back if their leg hurts or if their arm hurts.
Okay, Dr. Renaud, you were talking about maybe 2 or 3 months it could go away without seeking help. But if someone has tingling and numbness going down the arm, should they seek help sooner?
Not necessarily, and we'll touch on this a little bit later when we talk about radiculopathy, which is nerve pain. But as long as they don't have profound weakness, and as long as the pain is not overwhelming, they can actually wait. It's not really an emergency.
And so that's the key, weakness. If they can stay strong and it's just irritating, I have a little numbness here, don't panic.
Right, absolutely. In our primary care physician partners, family doctors, internal medicine doctors, they're fairly well versed in this, and they know that. And so they'll try to treat you initially with some medications and things like that, and just buy some time. And then if you're not getting better, they'll refer you. Okay,
let's go to the next slide, and we're talking about advanced imaging false positives. Dr. Renaud, what does that mean?
Sure. So, we talked about how common back pain is. We just talked about some of the anatomy of what happens. So we see patients all the time that come in who have gotten an MRI or some sort of imaging study, and they say, I've got a bulging disc, or I've got a herniated disc, or I've got, a dried out or degenerative disc, and they think something's wrong with their back. Well, these studies, and there's numerous ones, but here's 2 of them, where they just basically plucked people off the street who did not have any significant back, arm, or leg pain, and they put them through MRIs. And I think, 2 of the big numbers here to look at are on the bottom on the left there. They found about 20, and I think it was actually 22% of patients under 60 years old were found to have herniated discs with no symptoms. Okay?
So that's a shock to them. That's what you're saying?
Yes. It's just to show that there are degenerative changes or other abnormal, I'll put in quotations, lesions in the back that do not necessarily cause you problems.
Okay. So the point of telling us this is it's all part of aging.
Exactly.
And once again, we should not panic if we should learn of this through a diagnosis.
Exactly. And if you look at that next number, people over 60 years old, if you take those 2 things together, herniated nucleus pulposus is HNP. So if you take that and spinal stenosis, which is what Dr. Segebarth was just describing, that's over 50% of people over age 60 have some abnormal findings on MRI. So just because you come and see us and your MRI says, you've got a bulging disc or you've got, a dried out disc, it doesn't necessarily mean anything, okay? And you have to always correlate the pathology to what the symptoms of the patient are.
What a great point you're making here, because I'm sure patients come in and they're thinking, okay, I'm sick. There's something wrong with me. This is what I've been told I have through a diagnostic test. Do you put it into perspective, Dr. Segebarth?
Yeah, we try to, and a lot of it is fear. They come with a report or a test that shows some abnormality, and we try to emphasize to them that's very common, and that it's not necessary. You have to kind of correlate that with their history and with their exam to kind of know if that's really a problem. We kind of use this correlation sometimes, like gray hair disease. And
right.
People don't always think that's a clinical problem, and it's not. And neither
believe me, I can relate with that one.
So, but yeah, to put it in perspective,
Yes.
Using language like that, I think a lot of it is just fear when they come. We have such advanced imaging now that we can pick up, it's very sensitive. We can pick up any minor detail that in the spine, and the real key is knowing when that's really clinically relevant.
And that was going to be my follow-up question. When do you know it's time to do something? Dr. Renaud, let's start with you.
Sure. Well, we touched on a couple of the things. I mean, there are basically some red flag signs that we talk about. I think there's probably a few things that are really urgent to be seen for. And those are if you start to notice a change in your bowel or bladder function, meaning either you can't control your urinary stream or you can't urinate at all. Okay. If you develop numbness in the genitalia area, okay, those are signs that something's pressing on the spinal cord and is quite troublesome. Other things are if you actually notice frank or overt motor weakness. Basically a simple way to say it was if you couldn't walk or you couldn't move your arm all of a sudden.
Or if you couldn't control your bowels?
Yes.
Would that be another one?
Yes, exactly.
Okay.
So change in your bowel or bladder function, numbness of your genitalia, loss of the motor function of your arms or legs. Okay. Those are all kind of urgent scenarios where you should be evaluated sooner than later.
What's that telling the doctor? It's something in the lower back?
It can be from the neck or back, and there's some crossover. I mean, things like stroke can obviously affect the arms and legs. But if it's coming from the spine and we get those types of symptoms, it means that there's something really compressing the nerves to some extreme degree, and that something should probably be done sooner than later, particularly imaging to find out if it is coming from the back. And if it is, something may need to be done to take the pressure off the nerves.
And when you're talking about numbness down in the private area, there has to be a fine line there. If it ends up being a hip issue, if a patient is complaining of having a groin that has what am I trying to say, has been pulled. So that's why the diagnostic testing is so important, to make sure that it's not an orthopedic concern versus a back issue.
Well, if there's any concern like that, most of the time these patients are being evaluated in the emergency room. If there's a severe condition going on, and again, I would emphasize these are rare circumstances.
Right.
So we're talking about common spine conditions. This is very, very uncommon. But in that situation, it's usually an ER evaluation, and we would often be called as a consultant. And for the most part, we can diagnose that on a clinical exam based on our exam, checking motor and reflexes and doing a full exam. And then we get imaging just to confirm what we know or think by exam. But again, that's an uncommon scenario. And other kind of common reasons for why you would maybe need surgery is if everything else failed and it's something that's amenable to surgery. So again, getting back to a nerve being pinched, arm pain coming from a nerve that hasn't calmed down, that hasn't settled down with with all the conservative treatment like therapy and the other things that we do prior to even thinking about surgery.
I was ready to say, you guys were talking about surgical procedures tonight, but you would be the first to see what would be done prior to going to a procedure, correct?
Absolutely.
Okay.
Yeah.
Let's take a caller from here in Charlotte. We have Chris with us. Hi, Chris.
Hi, how you doing?
Hi, Chris. We have a great conversation going here, and thank you for joining us. What's your question here with the doctors from Ortho Carolina?
Oh, it's okay. What it is I've had MRIs done. I've had what's that in your lower back where they pick the needles up your back, cortisone shots.
Yes.
I've had pain management done, and I still have lots of pain in my lower waistband line.
All right.
And L5 or below.
So your question is, what would be the next possible treatment? What's the next step for you?
Yes, sir.
Okay, Chris, we're going to let you take this answer off the air, and we thank you. Here he was saying that he's gone through, the injections, L5, right before we went on the air. We were talking with the doctors that this is an area of the back. And Dr. Renaud, I think you have the spine here that you want to bring up and show us where L5 is. It's one of the most common areas, correct?
Yes,
Dr. Renaud?
that's correct, yep. in the low back in particular, the lowest couple of levels here.
Yes. So go ahead and show us what we're talking about.
In the low back, this is the L5 vertebra. There are 5 lumbar vertebrae. They're just numbered sequentially. So this would be 5, 4, 3, 2, and 1.
Right.
Okay. And, the L5S1 disc is right here, and it commonly degenerates or kind of wears out.
And that's what Chris is describing.
It may be what he's describing, yep. And also commonly the L4-5 disc space here commonly wears out. And we think it's probably because it bears most of the weight in the spine.
So for a patient like Chris, who's going through treatments prior to a procedure, we're not here to diagnose individual issues or problems, but what would a patient like him expect for the next round?
Sure. So, we'll talk about this a little bit later, but just getting back to what we mentioned, it's very important to correlate the clinical symptoms to the MRI findings. So, we don't know what his MRI is and all this, but he seemed to say they had predominantly back pain. Yeah. So most of the time, again, those are musculoskeletal conditions. And for him, I think the one thing I'd want to rule out or make sure that it's not is that he doesn't have some instability to his spine or
what does that mean?
Slip of the spine.
Oh, a slip.
Meaning sometimes when these discs, I don't know if we're back on the model here.
Yep.
But sometimes when these discs wear out, one bone actually can slip forward on another bone, okay? And it has to do with both the disc wearing out as well as Dr. Segebarth was talking about back here, the joints in the spine becoming kind of arthritic. So a combination of those factors, sometimes the spine can actually start to slip on itself. And those can be reasons for back pain that may need surgery.
And what type of procedures are out there to correct it?
Typically things where we kind of reconstruct the spine anatomy. So we'll decompress pinched nerve roots, but then we also kind of hold the spine in place, typically with things like pedicle screws and rods nowadays, or what's typically called a fusion surgery.
And these procedures, and we've had your colleagues on the air before, they can be open procedures as well as minimally invasive procedures. So there's a whole range there.
That's right. And anymore with spine surgery, it's such a rapidly advancing field. There's a lot of new tricks and tools and devices and different ways that we do this. And you want to have kind of all that in your arsenal. And you can't kind of treat everything with one procedure because it is smaller or it is less invasive, because sometimes that is the most appropriate thing. But other times it's not, and so trying to apply that to a condition that it's not going to help, doesn't necessarily have the best outcome.
That's why it's a custom fit, and that's
right.
why the doctor and the patient have good open communication of which procedure is going to be the best one for him or her, right?
That's right.
Let's go up to Mount Ulla in Rowan County. We have Merle with us. Hi, Merle.
Good afternoon.
Hey, Merle, refresh my memory. Rowan or Iredell County?
Rowan County.
I thought so. You're near West Rowan High, right?
Yes, sir.
Okay, what's the question? Welcome to HealthWise.
Okay, I've been evaluated at the VA in Salisbury with degenerated bones around my hip bone, around my disc.
Yes.
And I got lower pain that goes from my lower left back down through my groin all the way down to my knee on the inside.
All right.
I wondered what would cause that the most, because I can very hardly walk on it.
Okay, I want to make sure I understood. Are you asking if you think this is a hip issue or a back issue, or do you know?
They don't know.
They don't know, but with those symptoms that you just gave us, let's hear what they have to say.
Yes, sir.
Thanks for calling in.
Yes,
Dr.
sir.
Segebarth?
Sure, I'll take that. So, Merle, that's a pretty common scenario that we see in clinic. Obviously, without seeing you in all your imaging and examining you, it's hard to say where yours is coming from, but there is definitely some overlap between back issues causing back pain and hip pain, and can radiate down your leg, as well as the problem coming from your hip, say from arthritis of your hip, and it can feel very similar. But there's some maneuvers that we can do in the office just to kind of help distinguish that. And as orthopedists with a background in treating both conditions, I think that we can help delineate that just based on an exam.
All right, listen, we really appreciate you calling, Merle, and the best of luck to you, and let's hope that you can find out exactly what is ailing you. We have a call outside the market. We're going to Grafton, Ohio, and we have Sharon with us now. Hi, Sharon. Welcome to HealthWise. Are you watching us via satellite?
No, I'm actually in a hotel room visiting you.
Oh, so even though you're from Grafton, you're here in the Queen City.
Absolutely.
I understand now. Welcome to Charlotte. What's the question?
Well, I have spurs in 3, 4, 5, 6, and 7. I've had shots. I've gone to a chiropractor, and I've also had acupuncture.
Mm-hmm.
And nothing is giving me relief. What do you think would be my next option?
Let's hear what they have to say. Dr. Renaud, you want to talk to Sharon?
Sure. So it sounds like you're having neck pain predominantly?
Yes.
Okay. Well, is any of it going down your arm, or it's all staying in your neck?
It's all staying in my neck.
Yeah. So, these are difficult conditions to treat because, like we said, if it's a pinched nerve, it typically radiates pain down the arm. And so we can very successfully treat those types of conditions. It's a little more difficult when the pain stays in the neck or in the back. We term that axial back pain, meaning it's in the middle of your body, not out in the arms or legs. And what's difficult about it is the discs can maybe be a pain generator. Those facet joints we talked about can become a pain generator. Again, we want to make sure there's no actual slip or instability of the spine. So we've got to kind of decipher all those things. And that can be done partly on the imaging, things like MRI, CT, X-ray. And also it can be done through diagnostic and therapeutic injections. And those injections can be placed in different locations based on what we think may be causing the problem. So again, it's kind of hard to come in halfway through your treatment and tell you exactly what's wrong. But, you need to be seen by somebody who can take all these things into account and direct your care in a stepwise fashion and try to rule things out and get to the bottom of it.
Yeah, Sharon, it sounds like it's a red flag, and what the doctors here are saying is that it's something you can't ignore.
Absolutely.
Yeah. Well, listen, thank you. Safe travels, and stick around. These doctors are here in Charlotte at Ortho Carolina, so thank you. All right, let's go over to Gastonia now. Debbie, welcome to HealthWise. This is one of the areas where Dr. Renaud practices. What's your question?
I have had 2 neck fusions in the past at C3 and C3, C4, and C5, C6. And I have now re-injured it at 4, 5. It's ruptured, and at 6, 7, a little bit, a little of a bulge. And I've had the shot. I get the numbness and the loss of strength down both arms, into my fingers, a lot of pain in the neck and the center of my back. Would surgery have to be a 3rd time now?
All right. Here you have a patient who's had some surgeries, asking if multiple surgery is in her future. Dr. Segebarth, you want to talk with her?
Certainly. So, Debbie, that sounds like a kind of a complex situation because you've had prior work done there, and that's always a concern is whether indeed you need another surgery, and that's something that that's best evaluated by looking at kind of your whole history and all your imaging studies. But sometimes the best thing we can do is know when not to operate. But it sounds like you have discs at several levels that have become a problem, and if you're having the radiating pain down your arms as you described, it would be worth further workup to better determine kind of what needs to be done, because oftentimes we can't help that with surgery.
Yeah.
Yeah. Well, I noticed I got the MRI last week, and I noticed I always keep, since I've had so many surgeries, I always get a copy from my own records and put the disc in the computer, and it even stated in the report that there's I had fell on my left side back before Christmas, and it's just not gotten any better. It just has gotten worse.
Yeah.
And the MRI showed the disc and things that was damaged, but it also said there was some tearing. I don't know if it's little veins that come off the sides, each of your back or whatever, and it showed that the disc was pushing against the backbone, and then the backbone's pushing it, so it's kind of being pinched by both sides. The spinal cord is.
Yeah. Have they told you what has caused this? Have you asked the doctors?
No, I've been waiting to get in, and the doctor's been out of town, and I've been waiting for 2 weeks now after the MRI to try to find out something, and hopefully this week coming I'll get to find out something.
All right. Well, listen, we thank you for calling in. It sounds like she has waited long enough, and it's time to seek medical help. So, Debbie, thank you so much for calling in. Our hour is quickly disappearing. We're going to take a short break. You're enjoying HealthWise on WTVI.
An educational grant for HealthWise is provided by Ortho Carolina, a comprehensive orthopedic practice with locations throughout the Charlotte region. And viewers like you, thank you. If you would like support group information about tonight's topic or any other HealthWise topic, call SupportWorks at 704-331-9500.
We're exploring common spine conditions that could benefit from surgery. With us, Drs. Bradley Segebarth and Stefan Renaud of Ortho Carolina, having a great conversation, and the phone bank is lit up. And before we go over to Waxhaw, I have one more slide to share with you. We've been talking about the different procedures. This next slide actually pinpoints some the spine surgery that we wanted to talk about. So let's go to it. Let's see, is this going to be Dr. Segebarth?
Sure, I'll take this one. This is kind of a busy slide, so I'll just, but it's perhaps an oversimplification of what we can do as spine surgeons. There are a lot of new technologies and newer, more minimally invasive surgeries that we have and have been trained on, but the reason for having surgery still hasn't changed, and so in order not to lose the side of the forest for the trees, there's only really three things that we try to accomplish with spine surgery. So number one is decompress the neural elements. So that means unpinch the nerves. Okay, so if there's a nerve being pinched that's affecting arms or legs, we can unpinch the nerves. One goal of surgery.
Okay.
The next is to stabilize. So if there is if there's instability, whether it's from a fracture, from trauma, or just degenerative changes, if there's instability that's causing pain, we can stabilize that by fusion procedures. The other big category of what we can accomplish with surgery is deformity correction. So we're talking about scoliosis or sagittal imbalance kyphosis, where kind of a humpback that's causing problems in terms of your muscles compensating, and that can cause back pain. And so we can correct that with procedures as well. So those are really the three things that we can go after as surgeons that we can make better. So unpinch nerves, stabilize something that's unstable, or correct a deformity. And then the bottom half of the slide kind of talks about an order of reliability. So what's the expected outcomes with surgery? And this is really an oversimplification, but statistically, if you look at the outcomes for surgery, the best outcomes are with unpinching a nerve, so extrinsic compression with primarily appendicular symptoms. All these terms mean is arm pain or leg pain that's coming from something pinching a nerve.
Right.
If we unpinch the nerve very reliably, we get pretty good results with surgery. Second to that would be instability with axial pain, so neck or back pain, due to some instability or abnormal motion. Pretty reliably, only second to the first condition, we can help that with surgery.
All right, let's head over to Waxhaw. Sonia, welcome to the show. I understand, we're all getting older, so what is your question? I'm leading you right into it.
Right. Like I said to the receptionist, I've had 8 surgeries. 8 surgeries within the last 5 years. Before my surgeries, I never had any back pain. My pain is not numbing of the legs or of the arms. It's just in the center of my back. Not in my lower back, but in the center of my back. And it seems like when I'm working around in the kitchen that I get the pain. Then I go and sit down in my recliner, and then about 10 minutes later, the pain is gone.
Any of those procedures help your situation?
Which procedures?
Well, you said you had 8. Is that right?
8 surgeries.
8
yes.
surgeries. Did any of those surgeries help correct what you're going through?
No, I never had them before.
Ah, okay.
I just started them in the last couple of years. So I also have a heart condition, and so I'm always worried that if I don't get rid of the pain, that it, that it may affect my heart.
Right. Well, let's hear what they have to say. I think her question is, the older as we get, are we more susceptible to this pain? And here she's not having the numbing issue. It's in the center of her back. Dr.
Right.
Segebarth?
Sure. So that gets back to kind of the conditions that we were talking about with mostly back pain. One thing we'd be looking for is there any instability there, especially with prior surgeries. Sometimes there's not a complete fusion, or there is some wearing around the surgery that leads to some abnormal motion that can be helped with further surgery. Other than that, she had mentioned 8 surgeries.
8.
Yeah, and if this is a new problem and not something that was the cause of the reason for your other surgeries, then I think it needs to be reevaluated by a specialist that can obviously look into your history and take some X-rays.
Sonia, thank you so much for calling. Let's go to the next slide, and this actually shows a close-up, if not a diagnostic tool of stenosis. Correct? Is this an MRI? No, actually, this is what?
This is not an MRI, but it's just a schematic or an animation on the left. And then on the right-hand side of the screen is kind of a cross-section of what a spine would look like, say if it was out of a cadaver or something like that.
I see. So that's actually a picture of a model. So, let's go to the next slide. This is lumbar stenosis. So we're just showing the difference here, and that looks like, what, an MRI or X-ray?
That's right. So the top image in the top left corner of the screen is essentially the same as that animation and that cadaveric dissection that you just saw. So the white, you see kind of like a white stripe going down through the image. Okay, that's the cerebrospinal fluid, and there's a black structure going down the middle of it. All right, your back, your skin on your back is kind of bright white on the far right side of that image, and your belly somewhere off on the left. So we're looking from the side.
Right.
Okay? And then you can see as you're going down towards the top, there's nice white on either side of that black stripe, and all of a sudden it starts to kind of hourglass, and it gets pinched off entirely. So that's just depicting what happens in stenosis.
Oh, you can see that, yes, right there in the middle.
Exactly. And all stenosis means is just narrowing or pinching of the nerves in this case.
Let's go to the next slide, Dr. Segebarth. This pertains to cervical stenosis.
Yeah, so this is, again, like Dr. Renaud said, stenosis just means narrowing. The fact that it happens in your cervical spine, it can cause some different types of symptoms because in the cervical canal is the spinal cord. Lumbar spine, the spinal cord is already ended, so you have mostly free-floating nerve roots, and it's a lot more forgiving of a space. So the cervical spine, if you have stenosis or narrowing, it can cause symptoms in both arms as well as both legs. And the natural history of this, if we don't do anything, actually is not as favorable.
Okay, and then this slide depicts what?
Yeah, so this is an MRI on the left that kind of shows the same thing. It's looking at a patient from the side, and you can see there's a couple areas where the black stripe looks pinched, and that's your spinal cord. The white stuff is spinal fluid around it. So there's a couple areas where the spinal cord in this patient was actually was bruised. This was causing symptoms of both arm and leg pain and some weakness.
All right, so this next slide, radiculopathy, did I pronounce it correctly? Dr. Stefan Renaud, this is part of your area of expertise, right?
Yes, it is.
Did I pronounce it?
That's correct. Yes.
And what is this?
Well, radiculopathy is just a fancy Greek term meaning pain going down the nerve root. So that means pain in the arms or legs. Okay. So as Dr. Segebarth said earlier, that's the best kind of pain that we like to see because our success rate with treating that is usually quite good. Okay?
Okay.
And, these slides are just talking about how it's more predictable to diagnose it. It's more predictable to treat it. It can come from various things, herniated discs, degenerative changes like we talked about in the anatomy section. Anything that narrows or pinches the nerve can cause pain down the arms and legs.
Through medical procedures, through surgical procedures? through procedures as opposed to medication or therapy?
Well, anything that pinches the nerve can cause these symptoms. And usually what we do is we try to start with the least invasive procedures. And most people who have even a frank herniated disc or a pinched nerve, which is also called like sciatica,
right,
usually get better, about 90% of them, within 3 months with some conservative treatment. So things we do are activity modification, therapy, medications like anti-inflammatories, muscle relaxants, and sometimes actually neuropathic pain medicines. Okay? And after people go through those things, if they're still having symptoms, then as some of the callers mentioned, we'll order some diagnostic and therapeutic injections. And all those things will usually calm the nerve roots down and will let the body get over that irritation of the nerve root.
And then after that, perhaps a procedure?
That's right.
So that's your area of expertise, the surgeons. So does it kind of amaze you when patients come in and that's not the first thing that you have on your mind is to do a medical procedure?
Well, nerve pain can be very severe, excruciating, and you almost know these patients when they walk in the office, before they even get to the exam room, because you can tell it hurts. But if you do give it time, most of this gets better. And it's sometimes hard to, it's a hard sell to the patient to wait it out when you're in pain. But it's if you see them the first time and then you see them a week or two later, usually you notice a difference. It's whenever they haven't made that progression, that improvement over time that that we consider intervening.
And understand that the longer you wait with a pain like this, perhaps you're hurting yourself. You need to get treatment sooner than later.
Overall, like we talked about earlier, you generally have some time. It's usually not urgent.
I'm talking about long term. If you ignore a situation, thinking, okay, A, I'm going to see if it will get better. B, I'm afraid to go to the doctor.
I think we touched on it earlier. Usually that 6 week to 3 month mark. So 6 to 12 weeks, somewhere there. If your symptoms are persisting during that time, then I think it's reasonable to be evaluated by someone.
Okay, that's a good question though, because we get the same thing. Should we wait this out, and is it harmful to do so? And there are a few conditions, rare conditions, but a few conditions such as a progressive neurologic deficit, meaning you're getting progressively worse. You're getting more weak.
Weak is the key
or spinal
word here.
cord injury. Then sometimes you have better outcomes with with earlier intervention. And obviously, if somebody is in excruciating pain and is just not coping with it well, and certainly we can offer earlier intervention.
Okay, we have some callers. Let's go to Barbara in Concord. Hi, Barbara.
Hi.
What's your question?
My question is, I've been suffering from back pain for the past year and a half, and I've got bulging disc, and the doctor seems to think all my pain's coming from my back deterioration, and I hurt real bad right there at the center of my waist at the back, and it's like when I get up in the morning, like my back has broke, and I've tried acupuncture, all kind of those epidural shots, and I've had spinal decompression, and
sounds like you have tried quite a few things then.
I have tied up thousands of dollars in my back, and from one day to the next, the doctor told me if I didn't do something that I would be in a wheelchair before long.
So what's your question? What is the next step?
What else can I do for my back?
Okay, she's been through a series of treatments. What's next for a patient like Barbara?
That's obviously a frustrating situation, and it's not uncommon, but it's tough to deal with. And one of the toughest things about it is really making the diagnosis and determining what exactly it is that's causing the pain. I know you mentioned that you had several disc bulges, and it's hard often to know that that's what's causing the pain, because we like the studies that we had mentioned, there are several asymptomatic individuals that don't hurt at all that have disc bulges. So it really requires a comprehensive history and physical and to really know what's going on.
Barbara, good luck to you. We go to Fonda now in Gastonia. Hi, Fonda.
Hi.
Hi, what's your question?
Yes, I was wanting to ask a question about my husband has epidural lymphomatosis, spinal stenosis. Are there a surgery out there that would be recommended for what we can get that stenosis out of there or without damaging his spinal cord.
Okay, good question. What do the doctors say to that? Dr. Renaud?
Sure. I think, do you mean he has lipomatosis?
I believe the caller's been dropped.
Okay. Yeah. Well, I think that's probably what you're talking about. And what that means is just that you have kind of an abnormal amount of fat tissue. There's usually some fat tissue around the nerves to help protect the nerves in the spinal cord. And in some people, they just have a lot of this tissue, and it can be contributing, like we talked about, other things that can contribute to narrowing of the spinal canal. So yes, that's certainly something that can be fixed surgically and usually quite easily and successfully.
All right, Fonda, thank you. Maggie in Charlotte, you're up. Hi, Maggie.
Hi.
What's your question?
I had back surgery, laminectomy, in 2002. After little by little, I kept getting like the same symptoms as I had before, and I developed a lot of scar tissue because they did a subsequent MRI. Is there anything that can be done to remove the scar tissue that's pressing against my nerve?
Great question. Thank you for calling it in. Scar tissue, that's all part of the risk of a procedure, right? And scar tissue develops.
That's right. It's a reality with any surgery, and it can be a problem. And one thing with a prior surgery that we're always concerned about is whether indeed it is that level or whether it's another level that's causing the problems. Some of the advanced imaging that we can get, we order based on whether they've had a surgery. We order with different kinds of contrast to kind of delineate whether indeed it's from scar tissue that's causing the pinching of the nerves, or whether there's actually a new development, such as a new disc herniation. And if indeed it is due to scar tissue, sometimes we have to delineate whether indeed the nerves do have some chronic damage to the nerves, or whether that's something that can be alleviated by removing the scar tissue. But again, we're concerned that if we do that with surgery, there's always a chance that it can reform scar tissue.
All right. So I think what I'm hearing Dr. Segebarth say is, Maggie, be sure and get the diagnosis that it is scar tissue and something that's not new or something that has developed, right?
Right.
And if it is scar tissue, perhaps it could be addressed at that time. Amanda in Taylorsville, welcome from Alexander County.
Yes.
Hi. What's your question for Ortho Carolina?
Hi, I'm a fairly active 35-year-old woman, and last November I went to just simply turn, and my back froze up. When I went to the ER, they gave me a CAT scan, and they said I had a fractured L3 and L4. Now they briefly said in passing, I need a metal disc put in my back. I don't know what they are, what they're for, or what it entails, but I just wanted some advice on how.
Absolutely, and we thank you for calling. Let's hear what they have to say. Who wants to take Amanda's question?
Sure.
Dr. Renaud.
Well, from what it sounds like, you said you were just turning, I believe. So in someone who's young and active, that's very unusual to actually fracture or break a bone in your back with a simple maneuver like that. Of course, we can't say that's impossible. It could happen to you. But as far as putting a metal disc in your back, that's something called disc arthroplasty. So you probably heard of people getting hip and knee replacements. Well, we're starting to have the technology to do a similar thing, a disc replacement in the back. But actually, one of the reasons not to put a disc replacement in your back is if there is a fracture or broken bone. So I would kind of rule that idea out. I hope that answers your question.
Yes, it does.
Amanda, thanks and it's a good question, and thank you for tuning in. We have a few more slides to go through, and the phone bank is still full, so hang in there, callers. Let's go ahead and go to the next slide. And Dr. Renaud, I think you're going to take this one. It addresses what, the upper neck?
This actually is just can be talking about the neck or the low back. This particular slide is showing images from the low back. And on the right-hand slide, there's, again, an animation or a schematic. You'd have to flip it upside down to match the MRI image that's next to it. So in other words, the very bottom of that black and white image is the very top.
Oh, I see that,
yes.
Image. It's just flipped.
Right, so you can kind of see where the red circular structure is in the diagram.
Right.
That's kind of right where the arrow is sitting, that big black structure.
And what is this showing us?
So this is showing a disc herniation, which is very common, mostly in people 40 to 60 years old. And this is a very common cause that they drew it as some like jelly shooting out of a donut is the way we describe it. So you can see that kind of brown structure pushing out from inside the disc, and it's depicting hitting a nerve that's in green on that animation.
And it's irritating it.
Right, and the arrow in the MRI image is showing the same thing. The kind of black or gray disc material is pushed out right at the bottom of the arrow.
So the next slide is addressing the upper back, the neck.
Exactly. So this is the same sort of thing, just showing it in the cervical or neck area of the body. And it's just this other image on the bottom right just shows how the nerves tend to distribute into the arms and legs in a very predictable pattern. And when we take the pressure off of the nerves surgically or by other means, it helps with arm and leg pain very predictably.
All right, next slide. Dr. Bradley Segebarth, you're up. We're talking about a vertebrae compression fracture here, right?
Right, and this most commonly we see from osteoporosis or soft bone, but it can come from other conditions as well. And these are something that can obviously be painful, but for the most part, they heal well on their own. There are some interventions we can do if needed, if it's becoming too painful to mobilize. So.
Next slide, couple more, and then we're going back to the phone bank to wrap up our hour. This is another what, MRI?
This is actually an X-ray from inside the operating room, and the dark spot that you see in the middle of the bone is actually some cement augmentation. And you can see that in the middle of the picture there on the left, compared to the other vertebrae, which are well kind of blocked, they look like rectangles. The one in the middle is kind of squashed down from a vertebral compression fracture. And the picture on the right just shows it from looking at it front to back. And that just shows that cement has been placed in that fracture.
So that's another procedure that can be done to help this person get out of pain.
That's right.
Sakia from Charlotte, welcome to HealthWise.
Yes, I'd like to ask about the tailbone, pain in the lower back and, like way down.
Right.
And does that cause, it causes a lot of pain, and will it hinder your walking? And is there anything that can be done about the coccyx area?
Oh, good question.
Does everybody need to have one?
Okay, and is numbing also a symptom?
It would be, yes.
Okay, let's hear what they have to say. Who would like to take that? Dr. Renaud?
Sure. Well, what you're referring to is, you said it just right. It's called coccydynia, and it means pain at the very bottom of the tailbone. And usually it will resolve with non-invasive or non-operative measures most of the time. So things like activity restriction, you hear about people sitting on donuts. There's little patches that can numb the area and that sort of thing. And typically it'll go away. Now, another thing in this area is you have to worry about things like ingrown hairs, pilonidal cysts. There's a lot of other structures in there that are not related to the spine necessarily that can cause pain as well. But usually we do not have to remove the coccyx. That's very rarely performed.
Thank you so much, Sakia. The hour's going. Let's go to Kelly now in Charlotte. Hi, Kelly.
Hi.
Hi, what's your question? We just have a couple of minutes.
I'm calling about my teenage daughter.
Okay.
She's 17, and she's been having lumbar back pain for a year now. We've done a bunch of different things. We start out with chiropractic, and they end up sending us to a spine specialist at ortho. Her x-rays are normal. She had MRI. That was normal. They said it was muscular, sent her to physical therapy. And so she's done physical therapy for 4 to 5 weeks, all the exercises. She's not getting any better. And this kid's in pain all the time. So my question is, what do we do next? She's had the anti-inflammatories, the muscle relaxers, massage therapy. We're just kind of running out of options here and don't know what to do next.
Oh, let's hope she finds relief. Kelly, thanks for calling. We're going to take the answer off the air. We just have a minute, so who wants to take it? Dr. Segebarth?
Sure. It sounds like you've had the appropriate treatment. It's just not getting better. And sometimes we take it for granted that do the therapy, do the exercises, this is a benign condition and it will get better. But if it doesn't, I think it needs reevaluation. So if she's still hurting and she's not making any progress, I think you should probably come back in for another evaluation.
Kelly, thank you, and good luck to your daughter. This is the summary of what we've been talking about. Let's look at the full screen as we say goodbye. Who wants to read the 4 highlights there? Dr. Renaud, you're up.
Okay. Well, like we said, we talked about lumbar stenosis and cervical stenosis, both of them being narrowing of the spinal canal and nerves, can happen for various reasons, happens in everybody as you get older, normal degenerative changes. You want to take the second two, Dr. Segebarth?
Sure. Radiculopathy is just a pinched nerve, whether it's your arm or leg, neck or back, and compression fractures. So these are all things that we could potentially treat surgically, though most of them don't need surgery, and we can get them through without.
Great hour, Dr. Bradley Segebarth and Dr. Stefan Renaud. Thank you so much for being with us from Ortho Carolina. New to the Charlotte area, you got to come back.
Thank you.
Thanks for having us.
Good hour, and thank you, callers, for participating. As always, we hope that this medical broadcast has helped you become more health-wise. Go out and make it a great week.
If you would like support group information about tonight's topic or any HealthWise topic, call SupportWorks at 704-331-9500. If you have a comment or question about HealthWise, call 704-371-8836 or email us at healthwise@wtvi.org or go to the website wtvi.org. If you are interested in being a guest on HealthWise or like to sponsor a HealthWise program, please call Suzanne Milkey at 704-372-2442. Learn more about HealthWise and other local productions at WTVI.org. Go to our website and you will see current and upcoming events on air and in the community. That and much more at WTVI.org.